Next, we'll move on to our enhanced barrier precautions and a discussion on how to implement those. And finally, we're happy to welcome Travis Bass from VDH, who's here to talk about Project Firstline. As always, at the end of our presentation, we'll open up to a Q&A session. If you've joined our webinars before, you're probably familiar with me. I'm Samantha Christensen, the HAI Epidemiologist, and I'll be your speaker for today. Again, we're also happy to be welcomed by Travis Bass, who is the HAI Health Educator for VDH. First, we'll move into our COVID-19 situational updates. Across the country, COVID rates have increased. We're seeing on the right-hand side in April, the community transmission level across the country versus on the left-hand side, we have the transmission level for May. Back in April, there were 458 counties at a high level of transmission out of the 3,220 counties across the United States. Currently, as of May 4th, we do have 1,019 counties across the country at this high level of transmission, with most of these counties located near the northeastern portion of the United States. Our substantial levels between April and May have not adjusted too much, and the moderate level has also remained relatively the same, with a decrease in about 400 counties in this section. Finally, the counties experiencing a low level of transmission have also dropped since we last met, with over 100 counties fewer now in this lower level of transmission. Now, Virginia is currently experiencing a rate of 148.7 cases per 100,000 people in the past 7 days, which is almost 3 times the rate when we last met in April. This rate is higher than all of our neighbor states, with Maryland and North Carolina at a lower but similar rate of over 100 cases per 100,000 people within the past 7 days, and Tennessee, West Virginia, and Kentucky at rates all lower than 100 cases per 100,000 people in the past 7 days. Overall, the US average rests at a rate slightly lower than what we're seeing here in Virginia, with 130.1 cases per 100,000 over the past week. Now, over the past month, Fairfax County has experienced a steady increase in the quantity of COVID cases in the community. During February and March, case rates moved from a steady decline into more of a plateau. And now in April and throughout May, cases have risen across the county. Recently, weekly averages have tended upwards, moving from a rolling average of 130 cases a day to 400 cases a day. This increase in cases may be due to a combination of waning immunity, relaxed mitigation efforts, and an increase in the transmissibility of the current viral strain. Looking specifically at our long-term care facilities, this chart shows an epicurve of all cases that have been experienced by our long-term care facilities in Fairfax County. And you can see kind of the different waves that we have throughout the pandemic. The early spring of 2020 wave, we have kind of that spike again in the winter of that 2020 through 2021 period, and then the largest spike that we experienced through the winter of 2021 moving into 2022. Now, what this slide highlights is the kind of increase that we're seeing in long-term care facility cases, specifically in long-term care, which mirrors that of the rest of the county. So you can see here we have circled the current case rate that has that sort of upward trajectory. And what I've also done is highlighted here with a red arrow where we were in this time period in 2021 to kind of show the difference. So we are seeing a heightened level of transmission in our community, even more than what we saw during this period last year in 2021. Currently, there are 2 COVID outbreaks in our Fairfax County skilled nursing facilities, 8 in our Fairfax County assisted living facilities, and 0 in our Fairfax County group homes. Fairfax County is currently monitoring 18 long-term care facilities that have at least 1 or more COVID cases, which we wanted to highlight. This is activity that's definitely heightened over the past few months and something we wanted to mention here as well. Next, we'll talk briefly about the CDC community transmission levels. As you might be familiar with, the CDC has implemented kind of 2 different transmission levels, one that's for the general population and another that's used exclusively by healthcare facilities. The link to the transmission levels can be seen here. And I've also taken a bit of a screenshot of the web page that you can go to using this link. By default, this web page will show you a transmission level for the overall community. This is for people who are not associated with our long-term care facilities. However, by adjusting the data type, which you can see here is listed as community transmission, we can see the levels that you should be going based off of for all of your measures for infection prevention and control in your facility. Next, we'll talk about the BA.2.12 sublineage updates. So emerging variants, which we've talked about kind of a number of times during this webinar, can really alter the future trajectories of our pandemic. And this is because they are largely a part of increasing transmissibility, increasing severity, which can lead to more hospitalizations and more deaths. They can also limit the immunity provided by prior infections and vaccinations. So having these variants emerge in the community can really adjust or alter what we can normally expect from the COVID-19 pandemic. Additionally, genomic surveillance remains limited. So this challenges our ability to, first of all, estimate the impact of a strain in the US to date. So currently any strains in the US, the estimation of how much of an impact they've had so far. It also challenges our ability to estimate the arrival of new admissions or of new variants in the population. So this means that it can be difficult for us without the full genomic surveillance potentially required for a pandemic this size to be able to estimate when a new wave or a new variant might reach our communities. Additionally, because these variants are so unpredictable in a lot of ways, it can be difficult for us to estimate or predict what might happen in the future when we have a new variant enter the community. This is what we are currently seeing with the BA.2.12 variant. So this chart has a lot of information, but I will walk you through it. To start, we have information starting in January of 2022, and it shows basically the percentage of viral lineages that have been sequenced from positive tests. So in this dark purple color, which you can see on the left, we have the B.1.1.529 variant, which is going to be the first kind of strain that we saw from the Omicron variant. Over time, this variant's prevalence in the population has decreased, and we've seen an increase of the BA.2 variant, which we talked about last call. Now we're currently seeing an increase in the BA.2.12 variant, which has started at the beginning of April and has steadily increased in the community. Now, BA.2.12 predictions are BA.2.12 is expected to overtake the BA.2 variant in the upcoming months. On the left-hand side here, you can see the predictions specifically for Virginia as far as the prevalence of this new variant goes. So right now we're at a point where we're seeing roughly 20% of the specimens that are sequenced identifying this variant type in the community. This is expected to increase to a point where it's expected to be roughly about 95% of what we're seeing as of June of 2020. This is mirrored across the United States, but to sort of a lesser degree. It's definitely a bit more prevalent in Virginia, as in the United States, while we're also at roughly 20%, they're estimating that only about 85% of the sequenced genomes will have the BA.2.12 variant as of June of 2022. Now, with this additional variant in the community, UVA produces a modeling prediction about every 2 weeks to kind of show what they estimate COVID will look like in our community. And to break this down, I'll talk about what their model predicts for each of the lines that you can see here. The first is the adaptive blue line that you have at the top. This is a likely trajectory based on the conditions similar to our current experiences. So it utilizes the data that we've seen in the past to kind of make an estimate of what's to come. And this includes the immune escape that we've seen due to the Omicron variant. Now for the second curve, you can see in yellow the adaptive variant BA.2. And this adjusts for the projection based off of if the BA.2 variant continues to be the predominant strain in the population. Transmission rates for the BA.2 infections are roughly 30% more infectious, and BA.2 prevalence reached 50% on April 1st. What this model does is it accounts for the prevalence rates to rise to 95% by mid-May. Now, I'm going to skip the green line and talk about the red line and come back to it. The red line here is the adaptive variant BA.2.12. So this, instead of looking at if the BA.2 variant becomes the predominant strain in the population, the red line here looks at if the BA.2.12 variant becomes the predominant strain in the population. And this variant has an estimated 30% higher than the BA.2 variant when it comes to their transmissibility. So kind of stacking that 30% on top of that 30% as far as transmission goes. And they're also accounting for the prevalence of the BA.2.12 variant reaching 50% on June 1st, which we saw in that last model, and rising to 95% 4 weeks afterwards. Finally, for the green line that you can see here, this curve talks about the, it assumes that the BA.2.12 variant will become the predominant strain in the population, which we've seen is most likely based off of other estimates. But this also accounts for increased control measures that we can use to mitigate the spread of COVID in the community. So this has the same assumptions as the red line as mentioned before, but with increased mitigation efforts. And this curve accounts for mitigation efforts that could reduce transmission by up to 25% by June 1st, and what the case counts would look like if we have that mitigation effort in place. So now we'll move into a outbreak response review, and this will be very comprehensive, simply due to the amount of facilities that have reported new cases to us. So initially, the response criteria on our part is one or more COVID positive cases in a resident or a staff member in your facility. At this point, Fairfax County will come out to your site. We will respond to any single case that you have reported in your facility. And working through how we do that, this is a flowchart that shows our process once a COVID positive case has been identified at your facility. Now, the first step will be to contact your public health nurse if you are a skilled nursing facility, or to contact your liaison if you are an assisted living facility. Our teams will follow up with a site visit within 24 hours and initiate contact tracing while on site with you. They will recommend that you implement facility-wide testing, meaning that we seek to test everyone in your facility, regardless of their immediate contact with that case. Because these variants are so transmissible and the population is so vulnerable, identifying if there is anyone in your facility who might also be positive is really critical to containing the spread of the virus. Then they'll ask you to report any newly discovered cases within 24 hours to our HDNC inbox. This is an email address that you can use to submit your line list templates. Now, to continue reporting throughout your outbreak, we request that you send updates on any new staff or residents that have a PCR positive or an antigen positive test, any new symptomatic staff or residents in your population, the death of a resident or a staff member, or the admission to a hospital for a staff or resident in your facility. Additionally, when on site at your facility, the recommendation from Fairfax County is to, upon the discovery of one COVID positive resident or staff member, first screen all residents, staff, visitors, and contractors, and ensure that continues throughout your outbreak. Next is to pause or limit visitation. While in the past you may have suspended visitation, CMS guidelines would like to seek the encouragement or the protection of resident mental health. And so we might adopt or suggest you adopt visitation strategies that could cause you, for example, to have more visitation outside or in spaces where there is less potential for contact with other members of your community. Third, they'll ask that you suspend new admissions. This can be a huge factor in preventing the spread of the virus throughout your facility, as it prevents the ability for the virus to spread to new populations. They'll also request that you suspend group activities, salon services, and communal dining. These are strategies that can really help prevent the spread between your resident population specifically, which is kind of the most vulnerable population and the one that we're hoping to protect the most. Additionally, when it comes to communal dining, the adoption of single-use or disposable utensils and flatware can be really effective at preventing the viral spread. Finally, after 2 weeks of outbreak testing with no new positive cases, normal operations in your facility can resume. Now, we mentioned before the outbreak testing, and Fairfax County recommends broad-based facility-wide testing upon the identification of a COVID-positive resident or staff member. So this means to test all residents and all staff, regardless of their vaccination status in your facility. Any positive antigen tests that you utilize to test these residents and staff members will need confirmatory PCR testing within 24 hours if they are positive. Positive lab results can be reported to VDH through their point of care portal or through NHSN. Now, this outbreak testing has a certain pattern in which it should occur. So first, residents and staff members must be tested every 3 to 7 days, regardless of their vaccination status. And outbreak testing must continue until all residents and staff have tested negative for 14 days. Outbreak testing critically resets if a positive member is identified in your community. Here is an example of a calendar where you might experience an outbreak in the future. So if we had a staff member test positive on June 1st, we would recommend outbreak testing for 14 days. This means that you could conduct testing facility-wide on June 4th, June 7th, and then if there were no positive cases on June 10th, then outbreak testing, if there are no positive cases on June 10th, you would continue until June 13th. And on June 15th, if there are no positive cases, this testing could conclude in your facility. So it'll go for 2 weeks from the 1st to the 15th. Now, if, for example, you experienced a new positive case on June 10th, then this will reset our timer. So June 10th would then be the mark at which we would kind of go for 2 weeks of negative tests. So you could do testing on the 13th, the 15th, the 18th, the 21st, and the 24th. And if all of them were negative, then you could conclude with your outbreak testing. When you're testing long-term care facility residents, anyone with even mild symptoms of COVID-19, regardless of their vaccination status, should receive a viral test as soon as possible. This also applies to newly admitted residents and residents who have left the facility for over 24 hours, regardless of their vaccination status. Upon returning to the facility, they should be tested immediately with a series of 2 viral tests, and if negative, again, 5 to 7 days after their admission. Also, residents who have been exposed, regardless of their vaccination status, should have a series of 2 viral tests for SARS-CoV-2 infections, as recommended by the CDC. Now, for reporting of your positive tests, CMS certified nursing homes, so our skilled nursing facilities, may use NHSN or the VDH reporting portal in order to report these COVID-19 point of care positive test results. Assisted living facilities may report using the VDH reporting portal. Facilities only need to report to one of these systems, but should report positive COVID results within 24 hours, regardless of the system utilized. Negative tests no longer need to be reported, which should be great news. And then if using NHSN, SAM's access must be first upgraded to level 3 if you would like to be reporting your tests in this way. Now, we've also included a quarantine cheat sheet to kind of walk through who in your facility needs to quarantine. So starting on the left for those who need to quarantine, these are going to be symptomatic residents, regardless of their vaccination status, exposed residents who are not up to date on vaccination, new admissions and readmissions who are not up to date on vaccination. Those who do not need to quarantine include exposed residents who are up to date on vaccination, exposed residents who have recovered from COVID-19 within the past 90 days, and new admissions and readmissions who are up to date on vaccination. Additionally, of course, unexposed or asymptomatic residents do not need to quarantine in your facility. When it comes time to end quarantine, residents may be removed from quarantine after 10 days if they do not develop symptoms, or 7 days if they do not develop symptoms and have a viral test that is negative. All specimens for tests to end quarantine should be collected within 24 hours of the planned quarantine end, and the date of the exposure will count as day 0 when measuring the length of the quarantine period. So this means that if a resident was exposed on June 1st, their last day of quarantine would be June 11th, and they could rejoin the population on June 12th. Now, when you're establishing isolation and quarantine units, it's important to consider to separate your facility into different sections. So we'll look at establishing a hot unit for your isolation. This is for your COVID positive residents. Then we'll look at establishing a warm unit, which will be for quarantine for your COVID exposed residents, your symptomatic residents, your new admissions and readmissions. And finally, we'll look at our cold unit, which will be essentially the rest of your facility without COVID positive cases or people who may have been exposed to COVID-19. A best practice is to geographically space and section off your hot and warm units. So typically we've seen facilities utilize separate wings or floors of the building. And they can even utilize things like zip walls to really establish a definite barrier between the different units in your facility. Now, staff working in the hot and warm units should be cohorted. This means that they should be entirely separate from one another to prevent the spread of COVID-19 across staff members in your facility. So ideally, when working in a hot and a warm unit, staff should have separate nursing stations, restrooms, and break rooms that they can utilize without intermingling with other staff in your community. Staff should only be assigned to one unit of the building, meaning that staff working in the warm unit should not also be working in the hot unit. And if someone's working in the warm unit, they also shouldn't be working in a cold unit. Bundling care activities can minimize the number of staff entries into your warm and hot rooms. And we do know many facilities have specialists that might need to work with different residents. So a best case scenario is to have your specialists work at the end of the day and typically move from cold to warm and then finally to hot. There are a number of work restrictions that you can utilize when a staff member in your facility has been identified either with a COVID-19 infection or with a COVID-19 exposure. The conventional method for all staff members in your facility, regardless of if they are boosted, fully vaccinated, or unvaccinated, is to have them isolate for 10 days or 7 days with a negative test if they are asymptomatic or mildly symptomatic with improving symptoms. Now, if you have a staff member at your facility who is exposed and boosted, there are no work restrictions, with a negative test recommended on day 2 and days 5 through 7. If they are vaccinated or unvaccinated, the recommendation for exposed staff members is 10 days of quarantine or 7 days with a negative test. The contingency level is for facilities that may be experiencing difficulty with their staffing numbers. So when moving into a contingency or a crisis level, which we saw in the last winter period, we do ask that our facilities reach out to us and we can discuss kind of the mitigation efforts in order to kind of remain within their recommendations, but to protect the population as well. So for a contingency level, staff, regardless of their vaccination status, should isolate for 5 days with or without a negative test, and if asymptomatic or mildly symptomatic. At a contingency level for staff who were exposed to COVID-19, if they were boosted, there are no work restrictions. And if they were fully vaccinated or unvaccinated, there are also no work restrictions, but there is a negative test recommendation on days 1, 2, 3, and 5 through 7. Finally, in an absolute crisis mode, in which the facility may not be able to maintain normal operations without staff on site, when a staff member is identified as having a SARS-CoV-2 infection, regardless of their vaccination status, there is no work restriction with prioritization considerations. So if you have staff members who are asymptomatic, you might want them working in places where they could have like more resident interactions. If they are mildly symptomatic, you might want to adjust where they're working in the facility. At a crisis level as well, for staff who were exposed to SARS-CoV-2, if they are boosted, there are no work restrictions. And if they are fully vaccinated or unvaccinated, there are also no work restrictions, but to test is a recommendation if possible. Additionally, signage is one tool that you can utilize in your facility to really encourage the ability of your staff to comply with recommendations in your facility. So here we have 3 different examples of signage that you could utilize in your facility. The first is an example that utilizes or explains droplet precautions, where clean hands are emphasized and the use of eye protection is utilized by staff members as well. The second sign helps with the face masks do's and don'ts. At this point in the pandemic, many people are familiar with utilizing a face mask, but some of these signs can work as a call to action to remind people of best practices in the facility in order to keep people safe. Finally, the third sign has a image which shows how to properly utilize the sequence for donning and doffing in your facility, which is something that may be useful for an isolation unit before entry by your staff. Now, when an outbreak is occurring, visitation should not discontinue. However, there are some recommendations for visitation in your facility. So even if a visitor has met the community criteria, which is typically those 5 days, to discontinue isolation or quarantine, visitors should not visit if they have a positive viral test, symptoms of COVID-19, or close contact with someone with a SARS-CoV-2 infection. Typically what this last bullet point will mean is maybe they have a COVID positive child at home. That's something that we've seen relatively frequently as of late. Visitors with any of these conditions should not visit until 10 days have passed since their exposure or the start of their isolation period. So ideally, what this is emphasizing is making sure that visitors that are coming into your facility have not been exposed or could be spreading the virus upon their visitation to your facility. We also wanted to touch base on what up to date means as far as vaccination goes. And with the establishment of the second booster dose, the up-to-date vaccination definition has not changed. So this up-to-date vaccination still means just one booster dose. You will be considered up to date even if you are available, even if the second dose is available to you. That definition has not changed. So for the Pfizer and Moderna vaccine, the being up to date includes having a booster dose 5 months after the receipt of their second dose of vaccine. And for the Johnson & Johnson vaccine, this is a booster dose 2 months after the receipt of their primary series. Now, CDC and CMS have established some baseline testing recommendations for long-term care facilities. Now, for staff who are not up to date, which is only one booster dose, there are recommendations for routine testing in the facility. And this is based off of the level of community transmission, which you can find on the CDC's website. So on the left-hand side here, we have the level of community transmission. And on the right side, we have the minimum testing frequency for staff who are not up to date on vaccine. At the high and substantial level, the recommendation is for for staff who are not up to date to be tested twice a week. Fairfax County is currently in a high level of transmission, which means if you have staff members who have not received a booster dose in your community, the best practice is to have them tested twice a week. At a moderate level, the testing frequency is reduced to simply once a week for staff who are not up to date on vaccine. And at a low level, there is no recommendation for routine testing of staff in your facility. Now, these community transmission levels can also be utilized to guide what level of infection prevention and control PPE should be worn by staff during this pandemic. So here we have a similar chart with the high, substantial, moderate, and low community transmission levels on the left, and whether your staff are working with a patient who is in isolation with a confirmed SARS-CoV-2 infection in the middle column, and whether your staff are working with patients in your facility who are not suspected of having a SARS-CoV-2 infection. So on the middle section here, you can see that the recommendation for working with a SARS-CoV-2 positive individual will not change. This will be a gown, gloves, eye protection, and an N95 or higher level respirator, regardless of the community transmission level. Now, when working with residents who do not have a SARS-CoV-2 infection, this adjusts based off of the community transmission level. So at a high level, which Fairfax County is in now, and at a substantial level, the recommendation is to have source control and eye protection. Whereas once we reach the moderate and low levels, source control is the only recommendation at that time. Additionally, if you are interested in having staff members who, or primarily residents who are not up to date on vaccine, we do have a task force who can assist with getting residents who might have issues transporting themselves normally vaccination. So we have a task force called the Medically Fragile Task Force that will work with you to get residents in your facilities vaccinated. Our point of contact is Matthew Fondon, and his email address is here. We've also included an image of a spreadsheet and a consent form that might be required for your residents before they come out on site and assist with that vaccination. Next, we'll move into a conversation on our enhanced barrier precautions. So what are enhanced barrier precautions? This is essentially the use of gown and gloves during high contact care activities for high-risk residents as a means to disrupt multi-drug resistant organism spread. This is something that Fairfax County is increasingly focused on as MDROs, especially in the Northern Virginia, Southern Maryland, and DC area, have increased over the past few years. The idea here is to expand the use of personal protective equipment, sort of beyond the situations where you might have staff members who are exposed to blood or body fluids so that you can anticipate or protect those staff members from the spread from MDROs. Additionally, this reduces the necessity for residents to be restricted to their rooms, which can help increase or improve resident mental health in your facility. So one of the strongest benefits to using enhanced barrier precautions when working with someone in your facility who has a MDRO colonization is that by using enhanced barrier precautions, they do not require a private room and the resident is not restricted to their room. So it's much more freeing than some of the other protocols that have been utilized for MDRO positive residents in your facilities. Instead, they suggest gown and gloves, which are recommended for any high contact resident care activities. This includes things like dressing and changing your linens, bathing, showering, and providing hygiene, transferring or changing briefs or assisting with toileting, and device care use, which can include things like our central lines, your urinary catheters, any wound care, or feeding tubes. And these enhanced barrier precautions are also intended to be utilized for the entire length of a resident's stay in your facility. Here's an example of some signage that kind of talks about what enhanced barrier precautions are and how you might utilize them in your facility. So this is something that could be placed on a resident's door who is screened positive for an MDRO. And it kind of encourages staff members to first clean their hands before entering the room and when leaving the room, and to also don gloves and a gown when doing activities that include the things that we mentioned before. Now, enhanced barrier precautions are recommended for nursing homes and skilled nursing facilities who may have MDRO positive or colonized patients. It's not currently recommended in things like our acute care hospitals, our LTACs, assisted living facilities, or residential care facilities or group homes. And these recommendations are for residents who first have wounds regardless of their MDRO colonization status, are infected or colonized with a novel MDRO, and have an indwelling medical device. Now, typically, these recommendations for enhanced barrier precautions are not recommended when a resident has draining wounds, when they are in units or facilities where transmission has been documented or suspected, and if a resident has acute diarrhea or sites of secretions or excretions that are unable to be covered or contained. Now, why would we utilize enhanced barrier precautions? First, this is kind of a shift into a avenue for these MDRO positive residents that's a bit more freeing for them. This means that the enhanced barrier precautions are typically less restrictive and even more effective, as some of our studies have shown, than some of the other precautions that we've utilized for MDROs historically. Because residents in skilled nursing facilities are disproportionately affected by MDRO infections, and they typically have more complex medical needs, enhanced barrier precautions can really assist in protecting this community. Also, kind of well documented in the literature is that resident-to-resident pathogen transmission of skilled nursing facilities occurs typically in part through the healthcare personnel who are treating and working with these residents on a regular basis. So this means that one resident may be colonized, unfortunately, due to a staff member who worked with another colonized resident and has kind of acted as a vector in allowing that pathogen to spread. And residents who are colonized with an MDRO can act as kind of a catalyst for the silent spread of MDROs. Because it's very easy to kind of identify active infections with residents who have an MDRO, it can be a bit more difficult to identify simply colonization. And without identifying that colonization and working with them as usual, it can be easy to spread MDROs to other residents in your facility. Now, this is a chart that was taken from a study that looked at the contamination rate during interactions with residents in skilled nursing facilities. And here you can see in this chart on the left-hand side, we list different interactions, different actions that are taken by staff when they're working with residents in their communities. Now, looking at gowns and gloves for contamination use, you can see on the x-axis the percent of transmission that occurred and that contamination of those gloves or gowns by partaking in these activities with COVID or with MDRO positive residents. So the highest interactions or the riskiest, I guess, interactions with residents for the transmission of MDROs was assisting with linen changes, transfers, and personal hygiene. Now, one aspect that can be very beneficial in your community for limiting the spread of MDROs is the utilization of screening. And here we have an example of some screening that was utilized by the SHIELD program in Orange County, California. On the left-hand side, we have the baseline values of known MDRO prevalence in different facilities. So they looked at SNFs, VSNFs, and LTACs, and they have documented on the left the percentage that had a known MDRO. After a round of screening across all of these facilities, so all of the 14 SNFs, the 4 VSNFs, and the 3 LTACs, this program was able to identify that the true prevalence rate of MDROs in these populations was roughly triple what was known previously across all settings. So from 17, they saw a true value of 58, from 20, a true value of 76, and from 50, a true value of 82. So MDROs may be more prevalent in your facilities than previously known. And so utilizing screening and then following up on screening with these enhanced barrier precautions can really do a lot to protect the population that you work with. To be successful with implementing enhanced barrier precautions, there are kind of a couple steps. And the first is just to know your residents. So understand their MDRO status, what kind of indwelling medical devices they have or are utilizing in your facility, and wounds that they might have that require frequent dressing. Additionally, implementing and maintaining standard infection prevention control measures can really help to improve the reduction of your spread of MDROs in your facility. So this includes hand hygiene, which ABS is recommended before and after any hands-on activity with a resident. This means also including before donning and doffing gloves, always utilizing soap and water if hands are visibly soiled, before eating for your staff members, and after using the restroom. PPE use should be reviewed kind of on a consistent basis with your staff members so that they understand what is required of them when working in different situations. Additionally, ensuring that PPE is available for your staff can work wonders in ensuring that they're able to kind of comply with those recommendations. Environmental cleaning and disinfection can be very beneficial in preventing MDRO spread in your facility, as things like Candida auris are known to have been able to reside on surfaces for different periods of time. Daily cleaning and disinfection of high-touch surfaces is essential for this, but also ensuring that non-disposable and non-dedicated or shared equipment can be disinfected after each use to prevent this spread. One thing that we've seen with some success is the implementation of a Who Cleans What list for staff to ensure that environmental cleaning is happening routinely and that everyone knows what their role in that cleaning is. Auditing for these infection prevention and control measures in your facility ensures that these activities are happening consistently and correctly. And communication can ensure that the MDRO history of residents in your facility is known when they're transferred between a unit or a hall, or when they're transferred to another facility. And now I will pass things off to Travis Bass to give us a conversation on Project Firstline. Travis?
Hello, can everybody hear me?
We can hear you.
Okay, I just wanted to give everybody a quick update on some upcoming Project Firstline trainings that we're holding. These are the last two of a webinar series that we've been presenting. They're on Thursdays at 1 p.m. and I'll drop the registration in the chat box if anybody has any questions. These would be great to share with your staff development coordinators. This is great for, since we were talking about COVID, we are doing a training on how COVID spreads, and then another training on ventilation, source control, and hand hygiene.
All right, thank you, Travis. As always, please feel free to contact us. Our main number is 703-246-2433, and our CD Epi emergency phone for after-hours calls or weekend calls is 703-409-8449. Thank you all so much for attending, and we hope to see you next time on Friday, June 3rd, from noon to 1 p.m. for our next webinar. Thank you all so much, and we'll open the floor for questions. Okay, not seeing any questions, we can go ahead and conclude our meeting for the day. Thank you all again for joining us, and we hope to see you next time. Bye-bye.